Hello everyone, welcome to PhysioUnplugged. If you are new here, this channel is where we take clinical concepts that feel complicated and we break them down for you. Today's topic is something that every single physiotherapy student and clinician absolutely needs to know and know well. We are talking about orthopedic assessment, and this is not just a surface level overview, not a textbook definition. Here we are going to talk about a real systematic step by step framework that you can actually walk into your OPD and use. Okay, and by the end of this video you will have a clear 7-step process that is logged in your head and a script in your hands that tells you what exactly to do. So let's not waste any time and let's just go into it. This is my channel, that is the Physio Unplugged you are currently on. Thank you for being here, and you can share this with your friends if you feel like. Now, why systematic assessment? Why exactly are we doing this assessment? See, before I jump into the steps, let me ask you a question. Have you ever examined a patient? Ever? And you felt you are blank, like, where do I start from? Shall I ask the symptoms first? Shall I ask the history first? What exactly do I need to do? See, this happens when you do not have a proper system. A systematic orthopedic assessment does 4 things for you. What are these 4 things? First, it prevents you from any missing pathology. See, random examinations, they miss things like fractures, red flags, any referred pain, or any underlying situation, conditions that is not very well taken under consideration when we are in a hurry or if we are not following a proper examination. Then second thing is that the systematic assessment gives us an accurate diagnosis. Now, accurate diagnosis is when our findings are structured and they mean something. Okay, and another clinician, if he does the same examination, he will also get the same result. It means the diagnosis was accurate. Now, third, it saves you time. When you know what comes next, like if I know the step 1, 2, 3, 4, and so on of my assessment or examination, it will save me time to think and stand and just be like, oh, what should I do next? So if we have a proper structured assessment plan, we save our time and do the execution properly. Now, fourth and the most important part of having a systematic examination assessment is documentation. See, when we assess a patient or when we prescribe any medicine or exercise or anything for that matter to a patient, we have to document it so that we have the proof that we did this examination and this is the prescription that we made following the examination. So a clean organized finding make our notes medico legally defensible, so that tomorrow nobody can question you that see, you asked me to do this but I did this. So it basically acts as your legal and referral notes foolproof. Okay, now that's why we do it this way. Now let me just show you the framework how we are going to go about our assessment. See, here's our framework. It has 7 steps as you can see on the screen, and these are not random, okay? These are not random steps. They are very specific in order, from the least provocative test to the most provocative test. See, why are we doing it? Because we want our patient to be protected. Now, protected means that I want to acquire the maximum information on my patient before I stress the structures of his body. You will get to know about it as we proceed further. This was just the framework that this is how we are going to move. Okay, now let's talk to step 1. um Before entering into the details of the step 1, let me just tell you ki, that what exactly the subjective history means in one word. It means, what does patient tell you? What does patient, this is my short form for writing patient. So let me just tell you one thing. For me and my students, PT means patient and capital P and capital T means physiotherapist. I hope I'm clear on this. So what does PT, that is patient, tells you means subjective history, whatever he tells you, okay, in one word. Now let me just give you a brief about this here, and then we'll move on to the individual part of the examination. So this means, what does patient tell you, right? Now second is observation. Observation means, okay, the patient has told you whatever he wants to. Now observation means, what do you see? So what do you see comes under the observation. Now step 3 is active ROM. That means, how does patient do the movement? How does the joint moves on its own? So I'm just writing in short. Then comes the passive ROM. Passive ROM means, how does joint, now short form for joint is JT, joint moves when you move it, when PT, physiotherapist, moves it. See, these steps are a detailed study in its own that we are going to cover further. But here I just want you to know that what does these words mean in one line. Like if I have to explain in one line, what does ROM mean? Passive ROM mean? It means that how does the joint moves when the physiotherapist moves it, right? Similarly, resisted or MMT. MMT means MMT is basically a resisted testing. It means strength. Basically, we are measuring the strength here. ठीक है. Palpation means, what do you feel? Do you means physiotherapist feel. Now special test means, what does the evidence says? Evidence, right? If you are confused about what we have covered in what we have covered in this slide, don't worry, we are going to cover each and every step in detail, okay? Now I'll be starting with the subjective history. Now step 1, and I will say this clearly, that this is the most important step in your entire assessment. This is where you have a talk with the patient and you listen to them very patiently. We do not touch them yet. So subjective history, do not touch yet. Okay, you don't test anything yet. So here we have is, let me just write it here, no touch yet, no test yet. Okay, we just gather information. This is all about gathering information, as I have written here, that what does the patient tells you. What does the patient tells you comes here. Okay, now to understand the subjective history, we use a framework that is known as Socrates. Now, Socrates is basically a mnemonic that stands for site, onset, character, radiation, associated symptom, timing, exacerbating or the relieving factors, and severity. Now, site means, now let's just understand this. Site means that where exactly is the pain? Where is pain? Where is the site of the pain? And can the patient point it with a finger, or the patient says it is diffused? So pointing and diffused pain means, means when the patient can point a finger and says here is the pain, and diffused means he can say that okay, this part is hurting, but I can't point my finger to a particular point. So this is diffused pain. So this is understanding. So this is understanding the site of pain. Second comes the onset. So onset means that did the pain start suddenly or it was gradual. So sudden could be like an accident or a fall, for example, and gradual could be building over weeks. So it could be either sudden or it could be gradual. Okay, so these are the two options that we have in the onset. Then comes the character or the nature of the pain. So the nature of the pain could be what? It could be either sharp pain, like a sharp shooting pain. It could be a burning pain. It could be a dull pain. It could be throbbing pain. And it could be an aching pain. So these are the different types of pains. The characters, different characters that a pain can have. Then comes the radiation. Radiation means that does the pain travel anywhere? Like if a patient has a pain in the neck, so is the pain traveling from neck to somewhere else, like the arm? So is the pain starting from somewhere and then going somewhere else? This is known as radiation. And this can tell you about the nerve involvement, because gradually further we'll see the case studies and the different studies, examples I will show you in the upcoming videos. We will see that a pain that has nerve involvement is usually a type of radiating pain, and it radiates along the path of the nerve. Well, we'll study that also in the upcoming videos. Now, we are clear with the radiation. Then comes the associated symptoms. Associated symptoms means, does the pain come with the feeling of numbness or a feeling of tingling or any weakness, anything, any stiffness, any other characteristic that is associated with the pain comes under the associated symptom. Then comes the timing. Is the pain constant or intermittent? Is it worse at a certain time of the day? So this comes under the timing of the pain. Then comes the exacerbating and the relieving factors. So exacerbating factors mean the factors that make the pain worse. And the relieving factors, as the name suggests, what makes it better? What makes the pain better? Rest, movement, heat, cold, whatever it is. Then comes severity of the pain. So severity is measured by a VAS scale. So VAS is a visual analog scale. Visual analog scale. So in this scale, we have a rating of 0 to 10, and then we ask the patient that 0 is the baseline, means there is no pain, and 10 means the worst pain you have ever had. Then we ask the patient to rate their pain on a scale of 0 to 10. Mind you that this is done by the patient. The patient is going to give you the numbering. It is not done by the therapist. Therapist does not give the rating. This gives us a baseline to compare the follow-up. See, if there is a pain of like 9 or 10, it counts as an emergency situation. In that situation, we cannot go on with a conservative treatment. We have to involve medical treatments or emergency services. That is why it is very important to note the VAS scale. Now, beyond the pain history, we always have to screen for red flags. Always and every single patient has to go through a screening where we are asking them about the red flags. What are red flags? Red flags are the dangerous signs. The signs that tell us that this might not be a simple musculoskeletal problem but something dangerous. Red flags include night pain or the rest pain, severe unexplained weight loss, fevers or chills, bladder or bowel dysfunction, history of any malignancy, and bilateral neurological signs. And these changes the presence of these red flags, when if we notice one, we have to immediately go for a medical referral to the department that is concerned with it, okay, the specialists. Now finally, ask about the patient's occupation. Why? Because the patient can have a previous medical history, previous episodes, and then we also have to ask about the patient's goals. See, a goal for a normal individual and a goal for a sports person is different. Sports person versus a normal individual, the goal is going to be very different. So it is very important for us to know these things, that what was the mechanism of injury, what was the previous episodes like, if there was any functional or if there is any functional or occupational demand. For example, a sports person cannot sit at home for 6 months if he has an upcoming league or a game in the next 2 or 3 months. For a normal individual, the person might be able to accommodate with that, because if we ask a normal individual to take precautions, go slow, not stress their bodies for 6 months plus, they might be okay. But it is not possible for an active athlete, especially if they are in their peak of their career and if they are young. So it is very important for us to know the functional demands of our patient. Then medication and comorbidities, if they already have been on any medication and if they are already having any comorbidities. Then of course patients go for therapy, as I've said before. See, this good subjective history can give you 70% of your diagnosis. See, if you are a clinician, okay, you have seen many cases. If you are in the late years of your profession and you have gone through many cases, the subjective history itself give you 70 to 80% of the information that you need to know. See, you get an idea from here. So this is very important part of the assessment, and this must be taken care of properly with a lot of patience before you even lay a hand on the patient, right? Now this was our step 1, that was the subjective history. This video is going to be very long, so I'll be covering the part step 2, observation, in the next video. This is a detailed series, okay, and in the end I'm going to upload a quick revision video in which I'm going to cover the complete assessment in 5 to 7 minutes for the revision purposes. But if you are studying the assessment, orthopedic assessment, for the very first time, I request you to kindly go through these videos, because these are made in detail for a particular reason, and that is to understand the basics of assessment. Once if you see these videos in detail, next time you will be done and dusted with the revision video itself, because you will have the basics clear. So this was our part 1. I hope to see you in part 2, where we are going to cover the observation and further steps. Thank you for watching this video. Thank you for your patience and support.